Alright, today we'll talk about the pharmacology of Parkinson's disease, that is the drug we use for the management of Parkinson's disease. And before we go into the drug, let's first look at the disease itself, Parkinson's disease. Okay, so what is Parkinson's disease? This is a neurodegenerative disease. Neurodegenerative disease. Okay, so neurodegenerative disease that is characterized by three main symptoms. Okay, the symptoms include rigidity, then bradykinesia, and tremors. Okay, once you see these three classic symptoms, you know you're looking at a Parkinson's patient. It's usually seen in older individuals. Okay, so it's a neurodegenerative disease characterized by these three symptoms. Now, once there is rigidity, it means the tone of the muscle is increased. And if the tone of the muscles is increased, it means they will come down with what? Bradykinesia. The range of movement will be limited, so there will be bradykinesia. Then also, there will be tremors. This tremors in Parkinson is resting tremors. Is what? Resting tremors, meaning the patient is at rest and their hands are what? Are shaking. Are you getting it now? So these are the three main features of what? Parkinson's disease. Now let's look briefly at the pathophysiology. The main thing you need to know so that it will help you in the pharmacology of the drug we use for the management is that Parkinson's disease is characterized by what? Death of dopaminergic neuron. Death of what? Dopaminergic neuron. Dopaminergic what? Neurons. Okay? So these dopaminergic neurons are the ones in the nigrostriatal pathway. So due to death of these dopaminergic neurons, we will now have a concomitant increase in the levels of acetylcholine. So it's more like a seesaw. If I'm to put a let me put a diagram to explain what I'm trying to say. So just picture something like this. We have this is the seesaw here, then here is the balance. You can see that the levels of dopamine is going down, while that of acetylcholine is increasing. Okay, so we just picture this one as the overall pathophysiology behind. This is the main crux of the issue. Are you getting it now? So dopamine is down, acetylcholine is up. The dopamine that is down here is due to death of what? Dopaminergic neuron in nigrostriatal pathway. There's a place in the brain that is called substantia nigra that normally sends signal to the striatum. So imagine here the striatum normally send dopaminergic signal to the striatum. And in this striatum, we have some interneurons that normally secrete acetylcholine. The normal function of dopamine in this striatum is to inhibit this what? This acetylcholinergic neuron. Now imagine that this pathway is no longer there. It means that you will have excess of what? Excess of acetylcholine. That's why I said in Parkinson's disease, there is low dopamine as a result of death of these dopaminergic neurons. And by so doing, you now have high levels of what? Acetylcholine. What does that tell you about the pharmacology? It simply means that if you want to treat Parkinson's disease, there are two major pathways or two major ways. Number one way to treat this disease is that we should give drugs that increase dopamine or dopaminergic secretion or dopaminergic activity. Drug that will increase dopaminergic activity. And number two, drugs that decrease what? Acetylcholine. Okay, acetylcholine or cholinergic activity. Let me put it like this: cholinergic what? Activity. So these are the two main classes of drug: the drug that will increase dopaminergic activity, and the drug that will decrease what? Cholinergic activity. So let's start with the first one, the drug that will increase dopaminergic activity. It's very, very simple. What you need to know is that, look at this diagram here. Imagine this is a synapse, a dopaminergic synapse. Here is the receiving neuron. Okay. Now on this part, we need to know that L-dopa is the precursor for dopamine. So this is L-dopa going to form dopamine. Then this dopamine will be stored inside vesicle. So we all use DA for dopamine. Are you getting it now? Then subsequently, it will be released into the synaptic cleft, where it will bind to what? To dopaminergic receptors. Okay, these dopaminergic receptors are called D2 receptors. So again, this is the precursor for the synthesis of dopamine, which is L-dopa. It gets converted to dopamine by an enzyme that is called, the enzyme here is called dopa decarboxylase. Decarboxylase. Okay, this is the enzyme involved. Now, I will just put a diagram here to show the blood-brain barrier. Imagine here is your blood-brain barrier. So here is the CNS, here is the periphery. Okay, now here is your L-dopa getting converted to dopamine by dopa decarboxylase enzyme. Then dopamine will be stored inside the vesicle, then it will be released, then out on D2. It means that if I want, what am I trying to do now? I'm trying to increase this entire pathway. So the first thing I will do is that I will give the patient L-dopa. I will give the patient what? L-dopa. Now, if we're giving the patient L-dopa, just picture this now. This is L-dopa now. So if I give the patient L-dopa, L-dopa will what? Will pass through this membrane because it can penetrate the what? The membrane. Are you getting it now? It can penetrate the what? The blood-brain barrier. L-dopa can what? Penetrate the blood-brain barrier. So if it penetrates the blood-brain barrier, it will enter into the this particular nerve, then it will synthesize dopamine. What does that tell you? It tells you that if you give L-dopa, L-dopa will what? Will form dopamine. That is to say, L-dopa is a precursor for what? For dopamine, but not so quick. The reason for that is because L-dopa can also be converted peripherally to what? To dopamine by peripheral dopa decarboxylase. Okay, by peripheral dopa decarboxylase. That same enzyme that is converting L-dopa to dopamine inside the CNS is also present in the peripheral part. So you can also convert L-dopa to dopamine. And if you convert L-dopa to dopamine outside, dopamine is charged. It cannot what? It cannot cross through this blood-brain barrier. What does that tell you? If you end up converting your L-dopa to dopamine outside, you are going to reduce the bioavailability of L-dopa in the CNS. So the concentration of L-dopa in the CNS will be reduced. Now, in order to combat this, we give a drug that is called what? Carbidopa. So, carbidopa. So, carbidopa will come to this place and inhibit peripheral what? Dopa decarboxylase. Do you get it now? Peripheral what? Dopa what? Decarboxylase. That's what carbidopa will inhibit. And if carbidopa inhibits this enzyme, it means that my L-dopa will now be able to what? To cross through the membrane without being converted to what? To dopamine. So imagine a patient now that is taking L-dopa without carbidopa. That means that the amount of L-dopa that will be reaching the CNS will be reduced. And not only that, there will also be side effects to that, because if you notice, L-dopa will be shunted towards what? Towards dopamine. Are you getting it now? And if you shunt it towards dopamine, dopamine will have some extra side effects it will cause outside, as we'll talk about them later on. Do you get it now? So how many drugs have I tell you now? I've talked about L-dopa, that is our first drug. I've talked about carbidopa, that is our second drug. Now, what if we give agents that can directly stimulate D2? Remember, all we are trying to do here is that we are trying to increase dopaminergic synapse. We are trying to increase dopaminergic pathway. So what if we give drug that can directly stimulate D2 receptor? I believe that would be very, very effective, right? So that is where D2 agonist comes in. D2 what? Agonist. So D2 agonist like what? Like bromocriptine. Bromocriptine. Okay, bromocriptine. So bromocriptine is a D2 agonist that will directly what? Pass through this blood-brain barrier and stimulate what? D2 receptor. You get it now? Okay. So this is our what? Our third drug. Now another drug we can also give are drugs that can increase the release of dopamine. So they are called dopamine facilitators. Okay, so this drug is what we call what? Amantadine. So amantadine can also be given. This is drug number 4. It does not act on the receptor, rather it increases the release of what? Of dopamine. Are you getting it now? So this is for amantadine. This is drug number 4. Amantadine was actually initially developed for treatment of influenza infection by influenza virus, but now it has developed a lot of resistance, so we use it nowadays as a add-on drug in the management of what? Parkinson's disease. Are you getting it? So this is drug number 4. Then also, your dopamine here can be broken down. Let me just put broken down. Okay, can be broken down by monoamine oxidase type B. Are you getting it now? Now, what are we trying to do? We are trying to increase the levels of dopamine, right? So it means that if we can give a drug that can inhibit this MOAB enzyme, it will be effective in Parkinson's. That is where drugs like selegiline comes in. Selegiline. Okay? Selegiline. Okay? Selegiline will now be our drug number what? Drug number 5. So selegiline will inhibit MOAB from degrading what? Dopamine. Okay? So how many drugs have we seen now? We've seen L-dopa, which is a precursor of dopamine. We've seen carbidopa, which will help L-dopa or potentiate L-dopa. Then we've seen amantadine, which is a facilitator of dopamine. We've seen bromocriptine, which is a D2 agonist, a directly acting drug. Then we've seen selegiline, which acts in the CNS by inhibiting MOAB, B for brain here. You get it? We also have other MOA enzyme, MOA-A. What is MOA-B? Basically inhibit MOA-B. So that the levels of dopamine will be increased. Now, in this place, we said we gave carbidopa to inhibit this enzyme, peripheral dopa decarboxylase. But there's also another enzyme that can act on L-dopa. Are you getting it now? When that enzyme acts on L-dopa, it is going to methylate L-dopa and form what we call octo-methyl-dopa. Form what we call what? Octo-methyl-dopa. Methyl-dopa. Okay? This octo-methyl-dopa, let me take the blood-brain barrier a little bit off. So this octo-methyl-dopa will also compete for what? We now compete with L-dopa for transport into the CNS. What am I trying to say in essence? I'm trying to say that L-dopa can be converted to octo-methyl-dopa. And if it's converted to octo-methyl-dopa, it is going to compete for the transporter that normally moves L-dopa into the CNS. And that will not be good for us. So that's why we need to inhibit the enzyme that converts L-dopa to octo-methyl-dopa. The name of that enzyme is called what? Catechol-O-methyl-transferase. Catechol-O-methyl-transferase. So the last drug I'm talking about now, what? COMP inhibitors. They inhibit this enzyme, catechol-O-methyl-transferase enzyme. You get it now? Then lastly, this is drug number 6. Then for drug number 7, let me just put it here. We'll call them what? Anticholinergic. Okay, anticholinergic drug. The centrally acting anticholinergic drug. So with this, now I believe I've been able to explain to you the pharmacology behind the drug we use, just a brief overview of the drug we use for the management of what? Parkinson's. I said the drug are of two major types: those drugs that will increase dopaminergic pathway, and the drug that will decrease acetylcholine pathway, or they are anticholinergic. Now, for the drug that will increase dopamine, we started with L-dopa, which was a what? A precursor for dopamine. And we made mention that you need to give it with what? Carbidopa, to inhibit peripheral dopa decarboxylase, so that you can have more dopamine, more L-dopa entering the CNS. Then we also mentioned that we can give bromocriptine. Okay, we can give bromocriptine, which is a direct D2 agonist. Also, we can give amantadine, which is a facilitator of what? Dopamine. Then also, we can give inhibitor of MoAB, which is what? Selegiline. Because if you inhibit MoAB, the concentration of dopamine will what? Will increase. Do you get it now? Then again, if we can also give COMP inhibitors, we are going to decrease the conversion of L-DOPA to, this is for short, it's called OMD. Okay, so OMD, orthomethyldopa. Okay, then lastly, I talk about what? Anticholinergics. Don't forget, the main pathophysiology of Parkinson's is that you have more of cholinergic neurons as opposed to what? Dopaminergic neurons. Okay, so thank you very much. In the next video, we will continue with L-DOPA, which is the drug of choice in treatment of what? Parkinson's disease. Thank you.